I'm Dr. Brose. I'm a member of the clinical staff at Stanford University Medical Center, and I'm the developer and founder of the Health Education for Living with Pain program. Our program provides interdisciplinary services to patients both direct here in our offices and remotely, coming to you by telephone or video. Today we're here to talk about opiate tolerance. Opiate tolerance is the experience of having increased drug being required over the course of several days or weeks to produce the same effect. Most of our patients experience opiate tolerance after they take these medicines for some period of time. Most of you might have had the experience of being prescribed Vicodin or Tylenol with codeine or some other relatively weak opiate, and then noticing over time that the initial dose of 1 or 2 tablets needed to be increased to 4, 5, 6, even 8 tablets a day. This experience of increasing drug dose to achieve the same effect is what we describe as tolerance. While tolerance by itself isn't necessarily a problem, tolerance can present problems as we continue using opiates on a long-term basis. Our biggest concern with tolerance is perhaps best illustrated by an example of a patient that I took care of several years ago. This was a young woman in her late 30s who was on methadone, an opiate, for managing chronic back pain. She had become so tolerant to the methadone that she was actually taking 1 gram of methadone a day. Recognizing that methadone is provided in capsule sizes of 5, 10, and 40 milligrams, that means that even at the largest tablet size of 40 milligrams, she needed to take 25 of these large tablets every day to help manage her back pain. That's an enormous amount of tolerance to any doctor's standards. When this patient had an emergency problem with a burst appendix, she presented to our hospital at Stanford. I was called to see her after she'd gone through the operating room and was in the intensive care unit recovering. I was asked to help with her pain management, and after interviewing her and learning how much of the methadone that she took, we started using an aggressive titration of intravenous medicine. We used sufentanil, the most potent opiate that was available at that time. This drug is perhaps 1,000 times more potent than morphine, and we gave it directly intravenously to try to provide pain relief to her. I opened an initial vial of the sufentanil and injected it directly into her veins, trying to relieve the pain that she described in her abdomen. She had almost no effect. Recognizing that her tolerance was a big problem, we went forward and continued administering vial after vial after vial. As I aggressively pursued trying to get her pain under control, I realized that we just weren't going to be effective, and I asked the pharmacist to set up an infusion of the powerful drug sufentanil. Over the course of the next hour and a half, I stood at the patient's bedside trying to administer more and more and more of this medicine, trying to get her pain relieved, trying to work with her to help her understand that it was her tolerance and not some sinister problem happening after her surgery that was creating this uncontrollable pain. At about 2 hours after she entered the intensive care unit, the pharmacist came to me and said, "Dr. Brose, you're going to need to use a different drug." And I asked him why, knowing that sufentanil was the most potent drug that we had and we were already using massive quantities of it. He said, "Because you've run out. You've used up the hospital's supplies." Finding this hard to believe, I talked with him further and learned that we'd used all of the supplies that might typically be used for all of the patients in the hospital in the operating rooms the following day. When I inquired of him how much total medicine this was, he responded, $9,000 an hour. Recognizing that a decade ago, $9,000 an hour of pharmaceutical cost alone was an enormous amount of medicine, I think anyone who looks at this clinical anecdote can tell you that this is a tremendous problem. Tolerance created by opiates. Because of this tolerance problem, we recommend in long-term opiate management that patients limit their ceiling dose to no more than 200 milligram equivalents of morphine a day. That dose would be considered moderate by most. It might be it might be that you could increase your doses far beyond the 200 milligram per day range. But we've found successfully that by recommending our patients keep their ceiling doses to 200 milligrams a day or less, that we're able to help them effectively manage even when interval problems like ruptured appendixes or car accidents or other things that we can't control happen in our life. When patients who use opiates recognize this ceiling, they can either approach it by just using their will to not take their doses beyond this, or work with us on an intermittent basis to try to withdraw and reduce their medicines to give themselves what we call a drug holiday. Through our work together, we can help our patients manage their tolerance, whether it's through the intermittent drug holiday or whether it's through willful control of the drug ceiling. We can prevent the kinds of problems that happen with unaddressed opiate tolerance.